and the introduction to the ultrasound assessment of lungs with particular emphasis to its application in emergency medicine. I work as an emergency physician in Adelaide, originally from Australia, but I run a special skills post for trainees for a couple of years and have hopefully gained some experience and insights to how to scan lungs with application to emergencies. What we're going to do is we're going to give an overview of what lung ultrasound is and how it's applied. It's typically in standard radiology terms, often not performed by radiologists or sonographers, and much more applied to the scene of critical care and emergency medicine, and extending now into the fields of general medicine as well. We'll use some case examples to make it clear and apply the principles, and may touch on some training recommendations on an ongoing basis. At its basic principle, thoracic ultrasound has been around for a while, and at varying different stages, the sort of findings that you're going to see tend to break down at the simple level to either the ultrasound beam will encounter air with no lung, as is the case of a pneumothorax. It'll encounter aerated lung with subtle irregularities at that visceral and parietal pleural interface, and you can see that sliding relative to each other. As the amount of water increases within the lung, microbubbles start to appear on the lung surface, generating short path reverberation artifacts or ring down artifacts, often known as B-lines. As that amount of water increases, the lung becomes saturated and solid and starts to appear like liver, and this is what consolidated lung looks like. And then at the furthest extreme, the lung is pushed away by fluid, as is the case with fluid within the thoracic cavity, as in pleural effusion or hemothorax. Most machines, when they were first brought about, the machine manufacturer presets to do with the lung were typically very, very poor and designed purely to look for lung sliding, whereas thoracic ultrasound and lung ultrasound extends to much, much more. So it's important to check that the lung preset is correct. I typically recommend using a curved array transducer. Sometimes the linear array can be of use for fine detail of the pleural itself, or in pediatrics, but for the most part, the most accessible transducer to you is likely to be a curved array, as you would do for abdominal scanning. Just remember that artifacts help, so you should try and remove all optimization on your machine. Most importantly, taking off compound imaging. I typically start at a depth of 10 centimeters, which achieves a reasonable balance between seeing in the far field, but also shallow enough that you can see the pleural line. And your initial eye should focus on the pleural surface, along with the actual focus of your machine. So if you were to look at your machine setup, there's a couple of things that I want you to pay attention to. In this case, the focus has been set far too deep, and the pleural line is likely to be up here. The depth is currently somewhere around 15 centimeters, and this can probably be taken a little bit shallower. This is evidenced by the fact that an abdominal preset has been chosen in error. So what we're going to be looking at is we're going to be getting the focus shallow, and what we can't see down here is often your machine will indicate if compound imaging is on or not, and we'll talk a little bit about that a little bit later. There's been an international consensus statement as regards where to scan the lungs, and the principles are sound, except generally over time I've come to modify this a little bit to its practical application to where we scan. The reason I say that is that typically, if you think anatomically, zones 2 and 4, as described on this diagram, in most normal lungs and most normal patients are actually within the abdominal cavity. However, the principles of where the zones are, as in zone 1 being up at the top, 2 being at the anterior but lower margin of the lung, 3 being in the axilla between anterior and posterior axillary lines, and 4 being at the inferior margin, those principles remain true. Having scanned for a few years now, what we tend to do in our department is we omit zone 3. The reason being is that we rarely see additional pathology there, and patients tend to find it fairly uncomfortable having a transducer full of ultrasound jelly placed in the axilla. So I typically recommend zone 1, very similar to Lichtenstein's work. I'd recommend sliding the transducer inferiorly until you see the inferior margin of the lung, which would be zone 2. Zone 4, we would come to the posterior axillary line as far as possible posterior and slide inferiorly until we see the inferior margin of the lung and ideally diaphragm to get some anatomical landmarks. We're most likely to see most pneumonias and effusions at that lung base. Labels will be typically simplified with R1, R2, R3 and R4, and the same on the left. As a typical sequence, the way I would typically scan, I would typically scan, sorry, my bit. Zones 1, then slide down to 2 on the right, 1 and slide down to zone 2 on the left. I would then get the patient to put this right arm across to this left shoulder, which gives me good access to be able to scan zone 4. If the patient poses an infection risk, I may need to leave zone 4 on the left side till later, because what I don't want to do if the patient poses an infection risk is to be leaning across to here. I'll actually need to scan zone 4 on the left later when I come round. If we're going to apply to the scanning of people that we've got concerns about posterior lung pathology in the lower lobe, we may need to sit them up with the arms folded in front of them. This will rotate the scapulas out of the way. Zone 5 will be up here, coming medial to the scapula down to the inferior margin. We'll see the inferior aspect of the lung. Again, this corresponding to the same on the posterior aspect of the chest. Questions that you need to ask as you're doing your scan and reflect upon is, do you see A-lines? And A-lines is not a sign of pathology per se. It's more a long path reverberation artifact that you need to try and consistently have, because it implies that you are scanning that pleural surface at 90 degrees. If you see A-lines poorly, it may suggest that you're tangentially scanning that pleural line. And if that's the case, you're much more likely to see thickened pleura and artificially increase the generation of artifacts, which could disproportionately show you pathology when it's not there. Lung sliding is what is often described as the A profile. In other words, A lines are present, and we often would add an A prime after A to describe the absence of lung sliding. Whether a B line is present, and that's a short path reverberation artifact where ultrasound gets trapped in microbubbles at the surface of the lung, losing very little energy and causes laser-like projections to occur from the pleural surface. It's really, really important to make sure that your eye is drawn to the pleural surface, because if those artifacts are not generated from the pleural surface, it may be coming from something else that is not indicative of pathology within the lung. An example being if you've got cases of surgical emphysema. Is there fluid in the chest or consolidation? So this is an example of looking at the chest and looking for A-lines. So when we see these A-lines, what occurs is the ultrasound travels from your transducer down to the pleural surface, bounces off that pleural surface, comes back to the transducer, and if it's at a perfect 90 degrees, what will happen is that'll bounce back again between the transducer to the pleural surface and back on an ever increasing basis, but losing a little bit of energy as that occurs. And what that will result in is this generation of a replication of this pleural line, only at exactly the same depth again. And there should in theory be another fainter A line occurring down here. Other things to orientate you to: this is the pleural line, this is a rib with its shadow, and likewise here. And the reason it's important to scan across ribs is that that will give you orientation to where that pleural line is, as opposed to giving a pseudo pleural line that can occur up here. Lung sliding is that very subtle movement of the visceral and parietal pleura relative to each other, and most people when they're starting like to use a linear array because it's a little bit easier to see. So what we'll tend to see in this one is we can see that when we look at that pleural surface, you can see that slight subtle movement relative to each other. So this seems to be moving relative to these tissues. In the context of the curved array, that's much more subtle, and this movement is occurring here. And if you can't see it with a curved array, before you jump to changing to the linear array, just reduce your depth. And the error that the person's made in this case is that they've got it on an Abdo-Gen preset and their focus is not on the pleural line. And they've got their depth probably a little bit too deep. So if they reduce their depth, change their focus, start looking at the pleural line, they're much, much more likely to see the pleural sliding that they can see much more reliably here. If otherwise we look for pleural sliding, again the angle of approach isn't perfect on this even with the linear array. We see pleural or ribs here and here, which means that this is going to equate to the pleural surface that we're looking for. We've got a little bit of undergain in the far field here. So what we're going to be looking is relative movement of this should be static and this should be moving at the pleural line here. Be aware that sometimes it's very subtle if the patient is very short of breath. They're having very, very shallow breaths, so the relative movement will be less and it may not be as obvious as you would like on ultrasound. The other pitfall to make sure of is when people are breathing, you often will see a degree of movement in the superficial tissues. The way to minimize that is to make sure that your hand is anchored on the chest when you're holding the ultrasound transducer. So typically the heel of the hand rests on the chest and the transducer itself held as if you were holding a pencil. So we touched a little bit on it, but I'd like you to think about what the absence of lung sliding actually means. We have heard a long time before that absent lung sliding equals a pneumothorax, but if you think about what lung sliding represents, I think you get a much better idea of what could possibly cause no lung sliding. So things that are not going to cause lung sliding is if someone holds their breath, those lungs won't move relative to each other. If you intubate to the right main stem bronchus, the left lung will not be ventilated, so it will not move, and it doesn't mean there's a left-sided pneumothorax. A pneumothorax will obviously cause that in terms of things. And if you've got a condition that causes the lungs to stick together, either by a pneumonic process or post-pleurodesis, that's lung sliding may be very, very subtle or absent. So the take-home message is that absent lung sliding does not automatically equate to a pneumothorax. However, if you do see lung sliding, effectively it means that there's no pneumothorax at the site you have your transducer. Bear in mind that pneumothoraces, typically air rises towards the ceiling, but sometimes you can have localized small pneumothoraces. Touching on M mode, some people may have heard about stratosphere and seashore sign when looking through the pleural space. Most of the time I recommend just abandoning this. It's useful as a static representation of something that's moving, but much more efficient to use a clip. There may be subtle benefits, but in the terms of a rapid screen and rapid lung ultrasound, I wouldn't recommend sticking with N mode, so abandon it. It's making it more complex than it needs to be. B-lines, these are these short path reverberation artifacts, also known as ring-down artifacts, that occur at the pleural line. In this case, hopefully you can see these lights in the fog, as they're often described. They occur right up at that pleural line, so up here. You can see the rib shadows hopefully fairly clearly. By definition, they're supposed to erase A-lines as they pass across them. That's something that is something to be aware of in definition, but something that I don't think is going to be a great discriminator. They should travel the full length of the screen. Even when it's not obviously highly gained, you can see that they travel all the way. And by definition, they should be more than 2 in a rib space. So 3 or more in a rib space, or they're joined together, they're all fusing together. You need to make sure that that's not that. I'm just going to touch on B-lines, sorry, staying on B-lines. My apologies. I can't get my slides are stuck, my apologies. If you look at those B-lines, sorry, my slides are stuck to not be able to highlight. You can see a single B-line from a single point. When you have compound imaging on, what can happen is it can spread the ultrasound beam from multiple different angles. So from a single point of abnormality, you can have multiple different artifacts generated, and that's why it's important to have compound imaging off. In the next extreme, we've got consolidation. Lung looks like liver. You may see air bronchograms. So in here, you may see air bronchograms occurring up within the tissues itself. This is also known as a shred sign, like a shredded bit of paper, where you change from heavily consolidated lung into partially aerated lung. And these are like B-lines, but not occurring at the pleural surface. They're a ring down artifact that's occurring at the interface between aerated lung and consolidated lung. Other thing that's useful is that this is part of the diaphragm, and it can be useful to orientate yourself. When examining consolidation, what you'll find is coming off a lung preset can actually help you. Solid lung tissue and effusions can be better imaged when you come off your lung preset, and you can get finer details defined within this. It's often this so-called B prime pattern, so the annotation of prime indicates there's no lung sliding, which means that there's B lines, but it's not sliding. And the next step further, again, we're on a lung preset. We might see this effusion a little bit if we flicked over to an abdominal preset, but hopefully you can see the fluid that's sitting in here. We can orientate ourselves with this diaphragm, and we see B-lines that are starting to occur at that surface of the lung. The lung will always have some appearance of some degree of consolidation when it sits in an effusion, just because there's more fluid that's contained on the lung, and those microbubbles can form. Within this effusion here, I think it's also worthwhile looking within that to see if you see echogenic debris. Sometimes you see strands within that doesn't equate to it being an empyema, but it does predict that it's much more likely to be an exudate over a transudate. So now we've learnt the theory, we'll move on to some cases, and hopefully it'll put it into a little bit of light and perspective. So case A is a 41-year-old male. He fell off his motorcycle at a relatively low speed, complaining of right-sided chest and shoulder pain. They're tachycardic. Blood pressure is a little bit low. Minorly tachypneic, and SATs are all right, but they're on supplemental oxygen, which could mask hypoxia. So what do we do now? Like anything, we'll probably take a slightly more expansive history. We will do a focused primary assessment as we would do in trauma. And we would start considering at the end of our primary survey what kind of imaging, which is typically recommended in trauma to be the chest x-ray and the pelvis. But I've also heard that in the modern era of trauma care that the EFAST is rendered pointless. And there's a couple of ways that I would take slight issue with that. If your patient is a polytrauma and you're proceeding without delay to the CT scanner, ultrasound probably adds relatively little. If it's going to delay you in any way or form to the CT, you should admit it. However, I work in a hospital where we don't have immediate access to CT, and even when we're going fast, it can take quite some time to get there and get a result and get the imaging processed. On top of that, I think it's a bridge to those learning ultrasound to know what normal structures look like. Your skills that you learn doing trauma scanning will get you used to looking for pneumothoraces, lungs and hemothoraces. It'll get you used to what liver and free fluid looks like, and they can be applied to different situations such as a ruptured ectopic, which would cause large amounts of intra-abdominal free fluid. So moving back to the case, we proceeded to an EFAST. Some of these are kept as static images as opposed to loops, which would be preferable to be a loop. Parasternal long axis view here, not showing any significant free fluid on imperfect imaging, but we live in the real world. Likewise, a slightly overgained right upper quadrant view, but again, I can assure you there was no free fluid seen on his imaging here. In the left upper quadrant, there's no free fluid. Just beware the pitfall, of course, just at the interface between liver capsules and splenic capsules. You can often see this slightly hypoechoic area to the novice provider. That can sometimes look like free fluid. When there's free fluid, you will typically see it outside the border of the spleen, and it will contour to tissue boundaries as opposed to be contained within it. The pelvic view in longitudinal, admittedly, you need to scan up to the top of the bladder as well. This is but a representative image of the whole scan. And transverse imaging did not show any significant free fluid. Scan of his right lung. So what we have here is we've got rib with its shadow, rib with its shadow and pleural line. And whilst you see movement, I hope you agree you don't see relative movement of down here compared to here. It's all moving in unison as opposed to separately on the right. And on the left, this is a reasonable example, hopefully, where you suddenly do see that relative lung sliding. And this is his chest x-ray, which I would suggest to you doesn't show an immediately obvious pneumothorax, but given your suspicions on lung ultrasound, you'll probably look a little bit closer at this case. And when you start to look that little bit closer, you're going to see that he's got multiple rib fractures down here. He's got a scapular fracture out here. And relatively, this hemithorax is a little bit more lucent than this hemithorax. Take-home message being that a supine chest x-ray is readily recognized to miss a pneumothorax. And in this case, there were multiple rib fractures with a scapular fracture and a right-sided pneumothorax. Case B is a 41-year-old who fell onto a coffee table 4 days ago. He's been complaining of severe left-sided pleuritic chest pain that's been getting worse since then, but didn't want to seek medical attention. Further complicated by the fact that he's anticoagulated for a deep vein thrombosis following an ankle fracture. He's got a temperature that's just creeping upwards, tachycardic, blood pressure is on the lower side of normal tachypneic, and he's got impaired oxygenation. His cardiac views from a subcostal route showing his RV, LV, and no significant pericardial fluid. This small pocket of fluid is often seen as physiological lubricating fluid within the pericardium and is not felt to represent significant pathology. His right upper quadrant view shows his kidney here, inferior margin of his liver, and again no free fluid sitting within here or Morrison's pouch. On the left upper quadrant view, again just a representative image that we've got. We see this is a vessel at the splenic hilum and is not extensive enough to represent free fluid. This is his kidney, got a little bit of contact dropout, which means that we're not seeing that inferior margin of the spleen. But in around this area, we're going to scan down towards his toes to make sure that we're not missing a pocket of free fluid down here. And we're going to make sure that we see up high that a pocket of free fluid is not sitting above the spleen, which it wasn't in this case. When we look at his pelvis in longitudinal and transverse, there was no evidence of pelvic free fluid. And then we look at his left lung, just a little bit off axis in terms of where we are. So we don't have beautiful rib shadows, so rib and rib, which shows the transducer has been rotated a little bit, but we do see relatively nice lung sliding occurring on the left and also on the right side. I hope for that lung sliding, despite the contact dropout at either side, we can hopefully all appreciate that he's got that. In trauma, lung bases are frequently admitted by error, but given his pleuritic pain, we scan his left lung base. What we're seeing in this context is this is diaphragm, this is part of his spleen, this is his anterior surface of his lung, which is not really sliding terribly much at all relative to his thoracic wall. These are some B-lines that are being generated, and this is often known what is called a shred sign at the interface between consolidated lung and aerated lung with the B-lines. I would suggest to you that if you jumped straight to chest x-ray in this case, this area here would be readily apparent that we're going to struggle about telling the difference between hemothorax versus consolidation, but hopefully you can tell that the lung ultrasound was pretty conclusive that there was no hemothorax, and this was a pneumonia he developed rather than being related to his traumatic bleed. He couldn't cough because he was so sore and developed a pneumonia. CT was performed again, confirmatory, and again one of the reasons we struggle is because currently we can't link our images to the medical record, something that's often lacking with point of care ultrasound, and understandably the ongoing care physicians want to independently review any imaging that's been performed. So those of you who can integrate your point of care imaging with the medical record, I thoroughly recommend you do so, and we may get to the point that we can avoid doing some unnecessary imaging. Case C, we've got a 69-year-old transfer from a country hospital with severe left-sided pleuritic chest pain. Her chest x-ray was verbally normal, but imaging was not sent with the patient, and they were empirically anticoagulated for the presumption of a thromboembolic disease. They were afebrile, a little bit hypertensive and tachypnic, and because it was painful for them to breathe, they weren't breathing that heavily. Take-home point from this one is that although we talk about our zones in the chest, I'd recommend that you also scan where it hurts. And when we did it in this case, what you'll see is we've got rib with its shadow, rib with its shadow. This is going to be your pleural surface. You can see a B-line sneak in here, that's coming in here, but hopefully you can see this area of consolidation down here. Now with thromboembolic disease, although you can get subpleural consolidations that are often only about this big, this is a bit bigger than I would expect with a pulmonary embolus. So this is much, much more suggestive of a pneumonic process occurring. And whilst I said that we always look right in the center of the screen, we should always look peripherally either side and look at that information and then slide our transducer this direction to be able to look at it. What we may also do is rotate our transducer at this point and scan intercostal to get a better view, an overview of what we're looking at here. Again, this patient proceeded to CT, confirming pneumonia, but no pulmonary embolus. I think other considerations you've got to take in with lung ultrasound, it's not meant to be an isolated test. Unlike your referral tests that will only do abdomen, pelvis, and are much more restricted, you can do restricted parts of multiple different zones. And often, just as your clinical examination incorporates the assessment of heart and lungs, I'd consider always having a basic assessment of heart when you're looking at the lungs. You can get additional information in terms of a basic exam of left ventricular systolic function, RV function and size, whether there's a pericardial effusion present. If you're considering that they might have a pulmonary embolus, you should look for a DVT, not look at the heart. I see it heard again and again that people ask me to scan the heart in someone with a suspected pulmonary embolus. The reasons you scan the heart in a pulmonary embolus is to make decisions about thrombolysis, not so much to help you diagnosed DVT, I've seen saddle emboli with very normal looking hearts. You're going to have much more return on finding the presence of a DVT, because it's very unusual to have an incidental DVT and a clinical picture suggestive of a pulmonary embolus. So finding a DVT would be much more convincing for a PE than any abnormality on lung ultrasound. Renal obstruction can be helpful in the context of our resus patients, and if you've got time you can start playing around looking for a septic source. It depends on your time and your limitations and the right clinical context. Case D is a 77-year-old with severe shortness of breath, no pain. Tachycardic, hypertensive, and tachypneic. They're diaphoretic. Heart sounds are present. If we're lucky, we can hear them. There's a global symmetrical wheeze with poor air entry and no peripheral edema, and his ECG shows a left bundle branch block. I'd suggest to you that really clinically you've got a short list of what you're thinking about, but it's nice to have some confirmatory imaging. So in zone 1 we've got multiple B lines. Now unfortunately this scan is not optimal because the rib is right in the middle of the screen. Rib should be probably down here with another rib here and having this in the center of our screen. But nonetheless what we're seeing is, even accounting for technique, we're seeing multiple B lines, and they're starting to coalesce at each of these rib spaces. And when we look in zone 2, again we see lots on that left side. We also scanned zone 3 on this case, and even that's occurring with a suboptimal preset. And what we've done is we're scanned down to that left base, and in this case what we're also seeing is we're seeing a small effusion in here. So we're seeing lung here, diaphragm, and we're seeing an effusion sitting in here. When we go to the right side, imaging was fairly similar with multiple B lines in zones 1, 2, 3, and on zone 4 we see that diaphragm along with an effusion. So as we said, to go and look at the heart, we look at the heart as well to orientate left atrium, anterior mitral valve leaflet. Don't see the myocardial walls that well within this left ventricular cavity, but there's a number of clues that we're pretty sure that this has got impaired left ventricular systolic function, even though we can see reasonably ready contraction of that right ventricle here. And the other clue is that this anterior mitral valve leaflet is barely coming up to hit that interventricular septum. So all these things are saying that this person has significantly impaired left ventricular systolic function. When we go to short axis, we can again, so these are papillary muscles here. We're looking at the left ventricular cavity when seen in short axis, and this is the left ventricular cavity cut in short axis. And we see that this not only does it not contract, but it's got this sort of rocking motion. I think you'll often see that when someone's got a degree of underlying bundle branch block. What happens is there's an uncoordinated depolarization of your myocardial walls, and so you're going to see this kind of thing happening. Chest x-ray, no great surprise, is entirely consistent with acute left ventricular failure or sympathetically driven acute pulmonary edema. So treated for left ventricular failure with nitrates and non-invasive ventilation with reasonably rapid effect, and probably not the greatest clinical challenge in terms of clinically that ultrasound enhanced. But as it happened, we met this poor patient 2 years later. When we entered the registration details there, they popped up that we'd seen them again. They're now aged 80, and they present this time with a fever, and they were feeling weak, and they'd since been diagnosed as a diabetic. They were febrile, they'd been beta blocked with a heart rate of 68, and their blood pressure was 85 on 40 and a respiratory rate of 22. Oxygen saturations were 91, and their sugars were running a little bit higher. Examination, heart, lungs, abdomen and legs revealed they were all present, but probably didn't add terribly much to the clinical picture as regards deciding what was wrong. Before we start an ultrasound, we've got to look at our goals. So why are we doing this ultrasound? And if we're doing it for a training exercise, fine, that's okay, but it shouldn't be done at the risk to the operator and should not cause any distress to the patient. We've got to look at what our clinical decisions are. So I'd suggest in this case, what we're looking for is we want to know, why is that blood pressure low? And we can use that in terms of thinking about our classification of shock, be it obstructive, distributive, cardiogenic, or hemorrhagic. We may also want to decide how much fluid is enough fluid. In an 80-year-old diabetic who had admittedly many other comorbidities, the appropriateness of managing them in intensive care would potentially come into question and conflict with the intensive care unit. And so she was much more likely to be managed under ward-based measures. If you don't manage her hemodynamics, the likelihood of going to a general medical ward and having a very restrictive fluid strategy does risk that she would progress to significant renal failure due to hyperperfusion. And so what we're trying to do is give her just enough fluid, but not too much. An ultrasound can guide us in that. We can use the Rush protocol in terms of the cause of blood pressure, often described with the mnemonic of HIMAP, or tank, pump and pipes, being the heart, IVC, mediastinum, aorta, pleura and pericardium, or at its really simple, heart, lung, legs. Shock, as we said, is often divided into cardiogenic, hypovolemic, distributive and obstructive, which is all very well and good in theory, but much easier if you can actually look to see if the heart's not pumping, look to see if the heart's not filling and is pumping against no resistance, or if it looks like the heart is filling but is pumping against no resistance, or if we've got an obstructive problem, in other words, the right ventricle looks big and dilated, we've got a very stenotic valve, or we've got a significant pericardial effusion. So how much fluid to give? I would suggest that it's reasonable to consider that when you give too much fluid, it's the great fear on the general medical ward that they'll go into pulmonary edema and it will go terribly wrong. So they're very scared to give fluid. And in this patient, who we know has left ventricular failure, people are going to be very scared to give them fluid. And yet in sepsis, especially sepsis that's not likely to be a candidate for using pressors, we need to give just enough fluid to maintain kidney perfusion, but not push them into pulmonary edema. And in this case, I generally recommend using the Falls protocol, which is fluid administration limited by lung sonography. And when we use ultrasound, what we can do is we can continually keep ultrasounding those lungs. And when we've reached the limit of the amount of fluid we can give, you will start seeing B lines generated at the bases. And this will occur far before the patient starts desaturating or suffers any ill effects related to their pulmonary edema. So in this case, we looked at her heart again, slightly challenging imaging, as is often the case. They're not in the context of what you see from the textbook. Left atrium, left ventricle, left ventricular outflow tract, right ventricle, and as you can see, although we see very poor views of that left ventricular cavity, we can hopefully still appreciate that left ventricular systolic function is significantly impaired. Trying to look at or short axis, this is the left ventricular cavity in short axis. We can see anterior and posterior mitral valve leaflets in short axis and just see a tiny glimpse of that right ventricle. These images included because they're not the perfect textbook images, and I think it's important to realize that we often don't get them quite like they are in the textbooks. However, if they were in florid failure, one might expect their IVC to be significantly dilated, and it wasn't in this case. In this case, her IVC was readily collapsing, and this would suggest that something else is going on. So florid cardiac failure, you'd expect a backup and that IVC to be plethoric. When we look at her lungs on the left and on the right, we don't see any significant A lines when we're looking there. And right down to look at the bases, those pleural effusions that we saw that previous occasion, they're all gone. We don't see any B lines. And likewise on the other base, we can see evidence of bypass or sternotomy, bypass surgery. And I would suggest that medically, you might be worried about how much fluid you're going to be able to give this person on the basis of that chest X-ray. It's not floridly pulmonary edema, but it does give you pause for how much fluid you'll give. So she was obviously treated for sepsis. However, what we were able to do is we ended up giving her a little over 3 litres of fluid in the emergency department with restoration of an adequate mean arterial pressure. She was producing urine. She ultimately diagnosed as urosepsis as the source of her sepsis, and she was able to continue her care on ward-based measures and never got significant or any renal dysfunction that she did have rapidly recovered. And I would suggest that that's a good outcome. Case F is included really just to make you think about how we see these things on ultrasound and what's the reasons that they occur, rather than just trying to memorize what findings cause different things. So we had a 56-year-old referred by their GP who had limited language. We could make out that he had chest pain. He was weak and short of breath and had ankle swollen. And when asked if he drank alcohol, he would nod vigorously. And I think in the absence of an interpreter in a timely fashion, this was always going to be the maximal amount of a reliable history that we were going to get. His hemodynamics were relatively unremarkable and didn't give us clues to where we were going. He was a little bit icteric. He had a raised JVP. His heart sounds were relatively unremarkable. He seemed to have creps to his mid-zones in his chest. Spleen was suggestive that it was a little bit big, but there wasn't obvious ascites, and he had pedal edema. So I'll be honest, the way I was thinking initially was that this man may have a alcoholic cardiomyopathy, was my initial concerns. However, when we look at his heart and a parasternal long axis, so hopefully you see better views in this case, but a pretty good left ventricular systolic function. Again, not entirely excluding diastolic dysfunction, but it makes us pause for thought. When we look at his short axis view, certainly preserved left ventricular systolic function at short axis at that ventricle, with the papillary muscle here, and his left ventricular wall here contracting reasonably well. Again, confirmed on his apical 4-chamber view. So his apical 4-chamber, with this being his left ventricle, his right ventricle, right atrium, and left atrium. We looked in R1. Again, technique looks reasonable. We're seeing A lines implying that we're hitting the chest wall at 90 degrees, but we are seeing a B line starting to sneak in there in zone 1, and zone 2 we're starting to see a few more. When we look at zone 3, we're seeing even more B lines starting to appear, and at the bases they're starting to coalesce. Left side, don't really see B lines at the apex, but as we move a little bit lower in the chest, we're starting to certainly see those B lines appear and getting some coalescent and multiple B lines right down at those bases. So the summary of what we found, we've got preserved LV systolic function. The RV is not that big. There's no pericardial effusion. He's got diffuse B lines in his lungs. So we start thinking, is this a primary lung problem, or what else could be going on in this case? So other questions are, what's in his abdomen? Does he actually have ascites that is clinically undetectable? Could he be short of breath and have chest pain because of a pulmonary embolus, in which case we should look for a DVT? Pulmonary hypertension can be helpful, because if you had evidence of pulmonary hypertension, then we'd think about more this being a pulmonary fibrosis. But remember, his cardiac views didn't really look like a pulmonary hypertension. That RV didn't look big, and although we didn't check for proper right atrial or RV systolic pressures, looking at transtricuspid flows, really it's not strongly suggestive on what we've got at the minute. Chest X-ray we'll always do as a matter of course, but it was unlikely to be significantly contributory, and we obviously do an ECG. This was his chest X-ray, which really didn't help a great deal. And otherwise we didn't see a DVT. His spleen did look big and measured large, had poor right quadrant views but no obvious free fluid, and he had physiological peritoneal free fluid. So this is just an example of when you're really looking hard for free fluid. You can find it. I would argue that it's almost physiological. So just between these bowel loops, you can see this tiny pocket of free fluid. No free fluid in the standard pockets in the right or left upper quadrant or in the pelvis. So why does he have B-lines? So this is just another example of scattered B-lines are not always your ready for of ARDS, viral pneumonitis, cardiac failure. I would suggest that the reason this guy had B-lines is because he had early liver failure and hyperaldosteronism leading to fluid retention. Questions? Sadly, I can't agree to them real time. Any questions directly related to lung ultrasound I'll try and reply to at the bottom, but obviously won't be able to respond to real cases. Hopefully that's made you see a little bit clearer. At another video, what we'll try and do is we'll do some talks about interstitial syndrome, consolidation, lung sliding as applied to a number of different cases. Thanks very much.